Okay, so if everybody could take their seats, we're ready to start the morning conference. So during Alan's financial report, he mentioned that we had a ballot piece of paper in our lanyard, and it's just at the back of our name badge. So if you're a member of BEHÇET'S UK, you should have one of those in there. If you're a member and you don't have one, just go and see Judy in the admin desk at the back. She's got some spares. All you need to do is, once you have voted, is put it on the admin desk in the box. Okay, so that's just so you know where you need to put that. Okay, so I'm really happy again to invite Professor Rob Moots up onto the stage to give his morning presentation.
Great, welcome back everyone. Again, if you're watching this online, but you're watching it on another day in an evening with a gin and tonic, cheers. So we're really talking for the next 15 minutes so about treatment of BEHÇET'S, which is a crucial thing. And first of all, just the elephant in the room, this is a weird disease, isn't it? It's almost impossible to pronounce, and frankly, I don't mind how people pronounce it. I'm more interested that certainly clinicians and medics think about the disease, because you've got to think about it in order to diagnose it. And as a poor patient, it's really strange to have something that nobody's heard of, you can't pronounce, so you've got my sympathies. And I'm hoping over the next 15 minutes I can give you a bit of a snapshot view about how treatment is changing for this strange condition. Of course, this is Lucy BEHÇET. You don't see many moustaches like that these days, do you? He's was a Turkish dermatologist, and BEHÇET is a relatively common name in Turkey. It's pronounced that way, so that's why we say BEHÇET, but you can say BEHÇET'S or any variation that you like, and there's no problem at all. And because it's a strange disease, it's really been very challenging to treat. You can see on the on the left there, it says, "I'll give you something to ease your pain." I don't know about you, I think I'd rather have the pain than the treatment, clearly making things worse. And that's one of the problems that in BEHÇET'S, there's been treatment over the years where the side effects have been worse than the disease itself. And that's just a sad reflection of our ignorance. And then on the right, you can see that with the development of new treatments, the monoclonal antibodies, the biologics, these wonderful drugs, which if you've needed and had and benefited from, you'll know it can be really good, but it can be very scary as well. So this is a condition where there's a lot of challenges. Of course, one challenge is that many different parts of the body can have problems in BEHÇET'S. Many different consultants and treatment teams can be required. And that's one of the reasons we form the 3 centres of excellence, where our aim, and those of you that have attended the centres may kind of slightly differ on our thoughts on this, I hope not, but what we try and do is get all the doctors around the patient, rather than patient having to go to different hospitals with different doctors for the same problem. Because we've tried to rationalise expertise a little bit, it gives us the opportunity to look critically at the treatment, to understand where we're really bad, and we are really bad. You will know how bad we are, sadly, but we want to do better. We're bad because a lot of the treatments driven by how important the professor is. Yeah, don't laugh. But that's wrong. It shouldn't be led by that. It should be led by good clinical evidence, clinical trials, scientific understanding. And though we're great at understanding these in other conditions, in BEHÇET'S we're lagging behind. So we're very keen to be working with you, and I'll come back to why BEHÇET'S UK is so important in this, how we can move things forward in the future. And those of you who are patients looking in this, I really want you to be able to have some confidence to look forward in the future to getting better care. I hope you're getting good care now. You can tell me about it later. But whatever it is, I want it to be better in the future. And just very briefly, there are a number of areas where there are particular issues in BEHÇET'S but haven't really been covered very well. One is children and young people, and I'm glad we're going to have a paediatric dental trainee talking to us a little bit later about mouth care of children with BEHÇET'S. Reproductive health is a crucial thing, but often forgotten. I'm going to tell you a little bit later about how we've focused on that in the new recommendations for treatment. Psychological effects, absolutely fundamental, and you'll be hearing from Suzanne about some issues there. And after I've spoken, Jackie, our support worker, is going to be telling us about some of the work that she's been doing about helping you maximize what you can do to what you want to do, including when you want to work, to be working. So the geographical availability of drugs has been awful. When we started the 3 centres, it was a postcode lottery as to who could get the biologic drugs that we know can work. Now, I want you to all memorise this. No, I don't even want you to read it. All I want you to see is that's really complicated. It's the way we've convinced the commissioners that we're not going to waste all of the money on these high-cost biologic drugs because we'll be careful about it. That was state-of-the-art when we formed. It is now obsolete. And I'm going to explain briefly in a few minutes as to why it is obsolete. So basically, as you can see, treatment of BEHÇET'S is a bit of a puzzle. And for me, when I have one of you sitting in front of me, I've got to think, well, you know, what is there around? What's wrong with you? How can we help you? And what's going to be the drug that's going to give you the best chance of helping you and the least chance of causing a side effect? Because the truth is, there's no drug that we can offer anybody for any disease that we promise will work and we guarantee will never cause a side effect. So it's all a matter of a partnership between you and your clinician talking through what's going on, including, some of you know, a risk of death for things, and you know, we've got to be straight with that. So it's hard to pronounce, hard to understand, hard to treat. There's minimal evidence for treatment, and that's crazy, isn't it? So we need to do clinical trials in BEHÇET'S and also in people here in the UK with BEHÇET'S, because there's a thought that people in the UK with BEHÇET'S may have a slightly different type of disease than those people that come from the Silk Road countries. So we need to understand about drugs, not just in BEHÇET'S, but also BEHÇET'S here, because are we seeing things slightly different compared to other places? So, with that background, a very important question came up a few years ago. These fancy designer protein, often antibody biologics, there were 2 of them that were used extensively around the world. There was interferon, roferon, which was used a lot in Turkey, Greece, Germany, areas particularly where there was a lot of BEHÇET'S, and infliximab, which is given as an infusion. And that's what the rheumatologists in particular, also ophthalmologists and other people in the UK, are very familiar with. The drug on the left, roferon, was fairly cheap. The drug on the right, infliximab, at the time was very expensive. But nobody knew what to use and when to use it. And that stimulated us, particularly with the 3 centres, but also collaborators and universities from around the country, to persuade the Medical Research Council and NIHR, that's 2 big research councils, to fund a head-to-head trial of those 2 drugs. The idea was to see, was one better than another? Send the 2 drugs out to have a fight and see who wins the fight? Is there a way we can predict who can respond to one drug and not the other? And basically, that's the first and only head-to-head trial of 2 biologics in BEHÇET'S in the whole world. And we've completed this trial and we've just published it. The bottom line is we found that both biologics were pretty well equally effective, which was interesting. And that's important because not everybody can take the infliximab that is our first-line biologic. It's not suitable for some people, and some people don't respond. So having an alternative, which we know worked well, the roferon, was great. And interestingly, the side effect profiles were pretty comparable. It wasn't that one was a nasty toxic drug, which some people are quite rightly worried about, and one was a very safe, clean drug. No, both of them were effective. Both of them could cause side effects, but no huge great difference. All very exciting and great, until Roche, who the manufacturers Rofiron, decided to stop making it. Crazy. That's really a big bugbear for us, because here's a drug not suitable for everybody, but suitable for some people. It was made by a drug company to treat leukemias, hepatitis, and things like that. But because for those diseases, newer drugs had come through, it wasn't cost effective for them to actually make it for BEHÇET'S. So they stopped making it, and now it's available pretty well nowhere in the world, but it's another story. We're actually taking this up and lobbying with some drug companies to see if they can actually make this drug. It is made in a couple of countries in South America, if that can be made available for appropriate people in the West with BEHÇET'S. So a bit of a mixed picture, a great trial, but useless. Great trial because first time we could actually get a research council to fund this type of work, have a head-to-head of two important drugs, found that they both work, which is a really good result, but useless because one of them's no longer available. And that's just the publication which is coming out in the journal Rheumatology. So, well, that was an interesting thing. What we learnt is that we can do trials in the UK on biologics in BEHÇET'S. And some of you may have been in that BEHÇET'S trial, but clearly there's an unmet need. We needed more drugs. So one of the other drugs which is available to treat a variety of other diseases is secukinumab. You heard a little bit about that from Tony. It's used to treat forms of arthritis and skin problems. There's a theoretical role that it actually could be useful in BEHÇET'S. So what did we do? We designed a trial to actually look at this in BEHÇET'S. And in fact, some of you either here or watching could well be in this trial. The bottom line is, it's all the nice technical terms, phase 2, multi-center, randomized, double-blind, placebo-controlled, crossover study. In other words, it's designed to the highest standard of clinical trials. And it gave everybody the opportunity to experience that drug. Just to give you an idea, the initial cost was thought to be £450,000. In reality, it's cost £1 million to do that trial. Novartis, that makes the drug, have funded it. We've got a nice clinical research organisation that work with us on this, and my hospital have sponsored it. All well and good. In fact, even better, by doing this trial, we're saving you and me as taxpayers between £250,000 and £1 million because this drug was given free of charge. So what happened? Well, we needed 64 patients. It was only the 3 centres that were recruiting to this. Unfortunately, one of the centres was not able to recruit any of them for a good reason. Another centre was very slow. The vast majority of the patients were recruited from Liverpool. Because we were going so slowly, we needed to try and get an extension. And that was really causing me a headache. £1 million trial, we were recruiting slowly. If we couldn't get extra money, it was all going to close down. Even people on the trial would have to stop it. And that's been a real worry. But thankfully, Novartis have chipped in some money, PharmExcel have chipped in some money, and you guys, BEHÇET'S UK, have made a nice contribution so we could actually complete this trial. It came close to the wire because with 24 hours to spare, we recruited the final patient. If we'd have been 1 day later, again, the whole trial would have closed. So thank you so much for actually doing this so we can complete the trial. And next year, we're going to get the results. Patients seem to be liking the drug. The commissioners have said if the trial works, they will fund this drug for people with BEHÇET'S in England. So a lot at stake. If it doesn't work, well, we don't want to be using it. If it does work, we know the commissioners will do it. And that's been a nice partnership between research, between you as BEHÇET'S UK and a pharmaceutical company who's made the kind of stuck their neck out to fund a big trial on a rare disease, and it's good to have encouraged them to have an interest in that. Okay, just very briefly for the next 5 minutes or so, I'm just going to quickly run through about guidelines. We want to generate evidence to make sure the best treatment's available, but that happens slowly. What we've got to do is work out what's available, what should we use, and when should we use it. And to that extent, we had a joint collaboration between the British Association of Dermatology, interestingly called BAD, and the British Society of Rheumatology. I often go to meetings, and I used to collect the badge from the meeting, and there were so many of them, the hook that they hung on was about to break. So I now only saved 2 badges. One says, Prof. R.J. Moots nice, when I was working with the National Institute for Health and Care Excellence, and Professor R.J. Moots bad. It's kind of says it all, really. But it was jointly done with Ruth Murphy, who's a dermatologist in Sheffield. Living guidelines, as Tony mentioned, are important because they get refreshed when they need to be refreshed. So the guidelines that we've published, there's nearly 90 there, and I'm going to work through every single one of these with you now, or maybe not. Don't worry. Just going to highlight 3 main things. Key recommendations: to manage BEHÇET'S appropriately, there should be a multidisciplinary team. We need to get the doctors around the patient, not the patient going around a lot of different doctors. We don't recommend thalidomide. You'll be, I'm sure, pleased to know. We find it important to focus on children and make sure as they grow up they can transition from a pediatric care to adult care appropriately. Nobody's really looked at reproductive health. There is 0 evidence, so we're recommending, whatever the evidence, let's take this seriously. If you've got BEHÇET'S and you're planning a family, BEHÇET'S itself tends not to cause a problem in pregnancy, and pregnancy tends not to cause a problem to BEHÇET'S. But what we're very keen is it's managed appropriately by an expert obstetrician with expertise in medical disorders and somebody who's got expertise in BEHÇET'S. And we don't find that the mode of delivery tends to be driven by BEHÇET'S. So if a woman wants to have a caesarean section, that's her choice, but it's not the disease that's saying you must do that. The second thing that's important is psychological management, and Suzanne, who's going to be talking later, was one of the clinical psychologists in these guidelines, and she might say a little bit more about how we've developed a staged approach to making sure anybody with BEHÇET'S can have at least psychological aspects thought about and assessed. I won't go into this in any more detail, except this is the first time there's been any formalised approach to how we can manage this really important aspect of that. And if you're keen to look up things, it's published. In fact, it's published in 2 journals at the same time, so I get 2 publications for one, which is nice if you care about those things. And just getting towards the end now, living guidelines. This is just an algorithm of what means I have a big headache. So we've done the guidelines, we've published them, there's lots of publicity going on about it at the moment. I think it's very important that we recognise, and it's been mentioned I think by Jan, that BEHÇET'S UK has got the best guidance, the best recommendations, the best patient information, and we're keen to drive people towards all of that. There was a formality that meant it had to at least be mentioned about dermatology. But this is my headache. When new information comes through, we have to analyse it. If it impacts on our guidelines, we change them so they won't get obsolete. That's the idea anyway. Okay, so just to summarise, coming to the end of things now, and just to let you know, we won't be taking questions unless it's a really burning question at the end of the talks. We're going to have a whole session for questions and answers a little bit later. But don't forget, if you want to log a question, you can do it on the computer, your phone, or write it down, and we will make sure that we can address them. So BEHÇET'S hard to pronounce, hard to understand. It definitely is a challenge just for us as doctors to diagnose and treat. And if you're having to be treated with BEHÇET'S, you will know far better than I about all of the problems there. We'd like to think that our centres of excellence are driving up the care. You can be the judge of that. In fact, you should be the judge of that. We don't need everybody to come and see us in the centres of excellence. What we want is that if you've got BEHÇET'S, you will get the right care in the right place, which could be with us, or it could be in your local hospital with doctors that are interested in BEHÇET'S and who can liaise with one of the 3 centres if there's any problems. There are still gaps in treatment. It's still not great, our management, but we are doing our best and we want to move forward, and it's by working with you guys that we can know what the key agenda is that you want when we do a trial, that you can help encourage people to take part in it, and that you can tell us how we're doing. We really do need to know that. Guidelines are important, and as you can see, there are new recommendation guidelines coming out. We hope that's going to help drive forward the treatment a lot better. And I contend that we still need to do clinical trials, a lot of them, but these are expensive. You don't get £1 million all the time to be able to do a trial. We're fortunate we've got that. We've got Research Council funding, but that's all stopping. We need to start looking forward for new trials. And the final slide is all my friends in the Liverpool Centre of Excellence. Our patients that have come to Liverpool will recognise some of these people, but it's important we recognise the backroom people as well, like the database manager and the secretaries and all of the others. So thank you very much for listening to this. I want you to know that we do want to do our best. There are huge gaps, but together I hope that we can move forward with this. So that's all I'm going to say for now. My next job, a bit like Kermit the Frog, is to introduce all the guest stars, is to introduce a crucial person in our BEHÇET'S Centre, also in the 2 other BEHÇET'S Centres. That's our support worker. And I think Jackie is looking younger every time I see her. I think at home she's got this oil painting of somebody who's getting older all the time, and Jackie's getting younger. But Jackie's going to share with us about some of the things to do with work and BEHÇET'S.
Okay, thank you, Prof, for that very flattering introduction. I hate to disappoint everybody. Okay, so my name is Jackie, and I'm one of the 3 support coordinators. I'm based in Liverpool, but my esteemed colleagues, Jean and Rebecca, are here as well. So you can shout out, ladies, if I miss any important points. Okay, so let's look at this then. Oh, have you? Oh, darn. Oh, that's it, okay. So, work and BEHÇET'S. I would say this presentation has really been driven by our patients who increasingly are asking us for more support in the workplace. And as the slides go through, I'll explain why that's happening. Okay. So, where do our patients work? Well, they work across all of the sectors: construction, education, healthcare, every sort of sector as you can imagine. So when we see the patients and when they come to clinic, we as support coordinators focus on the non-medical aspects of living with BEHÇET'S. So when we're speaking to patients, very often work comes up. And our patients, some are employed, some are in training. We get a lot of young people going through apprenticeships. And then we have other young people who are perhaps at college or university and are thinking about entering the world of work. And then we have some patients who are unemployed because they're perhaps too unwell to work. And then we have other patients who might be interested in volunteering or already volunteering. So what do patients tell us about the difficulties they face in the workplace? And as you know, those of you who are patients, we know BEHÇET'S is seen as an invisible illness, so patients can look well and fit. It's also a fluctuating condition, so a patient can be in work one day and feel absolutely dreadful the next day because they've had a flare-up of symptoms. And one thing patients do tell me in the workplace that can often happen is trivialising of symptoms. So by that I mean, an example a patient gave me once was they had dreadful mouth ulcers. They went into work, and having a coffee or a tea in the staff room was virtually impossible because their mouth was so sore. Eating at lunchtime, just the general social interaction they find difficult. And chatting to other colleagues, they were met with, oh, well, everybody has mouth ulcers. I have mouth ulcers. So there's a lack of understanding about the mouth ulcers that patients would have in Behçet's. And you can understand why the general population wouldn't know about this. But because mouth ulcers can often be an invisible symptom, for this particular patient, it was one of the big problems about being in the workforce and being able to do their job to their best level. The other thing patients worry about is where they do have support in the workplace, they worry about their co-workers or their colleagues thinking that there's a level of favouritism, that they're being treated differently and in a sort of, favourite sort of way. And that's another thing that can affect patients' morale in the workplace. And one patient said to me they felt very isolated, they felt very lonely because they didn't have this understanding from their colleagues and from their employers. So, what can we as support coordinators do to help our patients who are already in the workplace? Now, the 3 coordinators, we will tell you that we have no expertise in legal matters or employment law. We simply start the conversation, and our role is to direct patients to the right support. And I think it's at having that conversation which is a really good starting point. So we make patients aware of their rights in law under the Equality Act, which applies to Scotland and Wales and England, but unfortunately not yet to Northern Ireland. Northern Ireland has its own legislation. They still have several different pieces of law that cover discrimination, but we have the Equality Act. And we're very lucky because BEHÇET'S UK have produced 2 excellent booklets, an employer's guide, of which there are copies at the back of the room, and these employer guides have been so popular, they go like hotcakes. And we encourage patients, if they wish to disclose that they've got BEHÇET'S, we encourage them to take these into the workplace and share with their employer. And they contain a wealth of information. And then more recently, we've got this other book called I Want to Work, which is written for the patient. And again, it is full of useful information and outlines the Equality Act and things like what can and cannot be asked at interviews. There are very strict guidelines about that, and we have had patients who've been asked about their health at the first stage of an interview, which is effectively contravening what the Equality Act says. We also encourage patients, where they can, to have links with their occupational health team. Many small companies don't have occupational health teams, so very often it's an outsourced service. And also if they can link in with HR. Now, this is based on patients wanting to reveal their diagnosis, and for many of our patients, they don't want to do that. They feel that's personal information and they want to keep that to themselves, and that is fine. We don't say to them, you must divulge to your employer. It's about the patient making that decision. And this is where the booklets are very helpful, because the patient can read through the booklet and decide what they want to do. The other thing as support coordinators that we can do, and I must emphasise our role is non-medical, but we can do a general support letter. So the patient can take that to their employer, which outlines, again, the Equality Act and what the employer's responsibilities are. So the Equality Act was passed in 2010, and I think it replaced probably 6 or 7 different laws. And it gives protection for those with a disability against discrimination. And under the Equality Act, an employer is expected to put in what is called reasonable adjustments in the workplace. Now, that can be really simple and 0 cost to the employer. That can be something like shift patterns. Perhaps if someone works 3 days a week, that instead of working Monday, Tuesday, Wednesday, if they wish, they could work Monday, Wednesday, Friday. So they may have recovery days, particularly if they're having a flare. The Equality Act also covers employers making available equipment, and that can be very low cost. That can be something as simple as providing a ramp or perhaps some assistive technology. Medical appointments is always a bit tricky. There is no obligation on the employer to give paid time for every appointment, and often appointments, for a lot of our patients, they're quite anxious. They'll be in the clinic and they'll say, I've got to get back to work for such and such a time. And as you're aware, at the centres, because it's a multidisciplinary approach, you can be at the clinic perhaps an hour, 2 hours. So appointments can cause a bit of anxiety for our patients. And very often what we say to patients, well, you can negotiate that with your employer. Perhaps they may consider that you have alternative appointments that you can take in the employer's time. Some employers will say, I can let you have the time, but unfortunately I won't be able to pay you. Or they might say, can you have an appointment first thing in the morning before you come into work, or perhaps at the end of your working day. That isn't always practical, especially somewhere like Liverpool, where our clinic finishes early afternoon. But these things, they're not written in tablets of stone. They're very often open to negotiation. And this is where the employer's booklet comes in. Very useful, because if the patient gives the employer the booklet and points out some of these issues, employers generally are supportive. Okay, so we've talked about the booklets, and as I say, there are some copies at the back. If you want to take one, please feel free. Now, this is where it may get a wee bit tricky. And again, we are not experts in employer relations or trade unions, but there might be an occasion, and we hope there isn't, where the patient might have to talk to their trade union for some advice as to how to proceed if the workplace is becoming difficult. Not everybody's in a trade union. Nowadays you'll find lots of small companies that perhaps don't recognise trade unions, or perhaps patients haven't joined trade unions. On those occasions we might have to say we need to direct you to another agency, and Citizens Advice do have employment specialists who, and I have found, have been really helpful when it comes to ironing out these issues. Also, there is the ACAS, Advisory Conciliation and Arbitration Service, and some patients may wish to go there. What would be ideal if we didn't have to get to this point, that there was two-way negotiation between the employer and the patient. We do have patients as well, after a period of time, may wish to enter the workforce, and that's quite a big challenge, particularly if you've not been well. Perhaps you've had a lot of flare-ups and you're lacking in confidence. And very often our conversation will be around confidence building and finding out what they do, what they want to do, what they feel their career aspirations are. And again, in the Employer's Guide and in the I Want to Work Guide, there's very clear information about what can and cannot be asked at interview and what would be a breach of the Equality Act. And again, we're not experts in employment, so we would very often signpost patients to other areas for specialist help. Some of the specialist help can come from Job Centre Plus, and they have very specific teams that deal with people who have disabilities in the workplace or entering the workplace. And they have a work and health programme, and they also you can have access to a work coach or a disability employment advisor. And in fact, in the next few weeks, I'm actually meeting a disability employment advisor who is very interested to find out about BEHÇET'S and understand better that if they do have a client who comes to them who has BEHÇET'S, they can understand a bit more clearly about what BEHÇET'S is about, and because, as we know, this is an invisible illness and patients can look well. The Job Centre Plus can also help patients with writing a CV. I mean, that's a skill that often needs a bit of polishing. They can help with job application forms and interview skills, which are, if you've not been in the workplace for quite a while, all of this can be very, very daunting. There is a scheme, a government scheme called Access to Work, whereby the government will pay, once a person is either appointed in a job or is actually started the role, will pay for help for that person. Now, the help can be something as simple as perhaps helping with equipment where it's a very small firm and perhaps they haven't got the financial, they're not able to provide the finance for making adaptations such as a wheelchair ramp or perhaps some assistive technology, and the Access to Work scheme will pay that, and they're actually quite generous, and they will also pay for the larger companies, although they do expect the larger companies to contribute. In some cases, Access to Work will actually pay for a patient to have a support worker who could perhaps go with them into work, take them on the bus or the train or whatever. So it's very personalised, the Access to Work scheme, and each client is accessed individually, and it does work. I have had patients who've said the Access to Work scheme has absolutely revolutionised the way they've been able to cope in the workplace. Patients often worry, and quite rightly, if they're on any particular type of benefits, that these could be jeopardised by going back into the workplace. There are a number of benefits that can remain in place. The most important one is personal independence payment, which patients can continue to claim when they're in the workplace. And that's often, of course, a concern for patients. But we would recommend patients go to their local welfare rights or citizens' advice to make sure they know what benefits they can claim while they're in work. And as we all know, any of you who are parents, childcare costs are phenomenal. And that's the one thing that can often be a barrier to patients being able to go back to work. So the government has brought in recently new legislation on childcare costs and fees. So we would direct the patient to citizens' advice to have a benefits health check to make sure that they're not missing out on anything such as childcare cost support and things like working tax credits. And that is the end of my talk. Thank you for listening, and as I understand, there's going to be a panel later on if anyone would like to ask me any questions.
Thanks, Jackie. You can also grab Jackie over lunch and things if you want to ask her further questions, but support work is a crucial part of our work in the BEHÇET'S centres. So for our next talk, that's the last one before lunch, it's great to introduce Martin Twycross from Dendrite. You'll have been hearing, particularly Tony, talking about the importance of developing a registry, and we totally support that. I think for a rare disease, we can learn a lot about the disease from a registry, and I'm really hoping that we can all push together to allow that to happen. And Martin's going to say a little bit about his experience of working with registries and rare diseases. Martin.
Good morning. Let's see if I can work the technology to start with. Am I going the right way? Oh, there we go. Good morning. Last year I sat quietly at the back with Amanda, and this year I've got to sing for my supper. I'm also acutely aware I'm what's behind you, between you and lunch, so I'll try and be as good as Jackie and be spot on time. As you can see, it's Martin Twycross. My background is engineering, and I come at this from an engineering perspective, not a medical perspective. So, as what I'm going to do is the usual disclosures for any presentation. I want to just define what a registry is, so we've got a clear understanding of what we're talking about. And then I want to look at 3 examples where we've provided different types of registries. And just to summarise that with what makes a registry successful, or what can make a registry successful. So, disclosure, I work for a registry company. About 4 or 5 years ago, I started working with Beacon for rare diseases, formerly known as Find a Cure. And I said to Rick there that I'll happily give him my knowledge impartially and without obligation. And I've done that to many groups. A couple have chosen to come with us, many are still thinking, and a couple have gone off in a different direction. And I say, brilliant. Dendrite's been going for a little over 30 years, in fact, I think 33 years next month. We were founded by a medical doctor, and we have a very sort of caring ethos. Currently, in that 30 years, we've developed a little over 200 registries, primarily from a clinical perspective, so by clinicians, for clinicians. Starting with cardiothoracic surgery, we developed the UK National Adult Cardiac Registry, which is still running, although it's been taken into academia. We span the globe, through America out to Australia and New Zealand, where we do the breast cancer registry and the trauma registry. Everything from A to Z, allergies to vascular, and I wait till we get to the Z so I can say everything from A to Z. So what is a registry? Quite simply, it's a posh word for a database. I think that's the simplest way to say it. So you can do with this whatever you want to collect in there. So in the sense of a clinical one, we use a database which is the same as the patient administration system called Epic, and they reckon they've got sort of 55% of the market share globally. So it allows a clinical team to specify what data they want, and that can be collected. And then we output that data in terms of reports, in terms of dashboards where you can compare your results against the whole database or against other groups or whatever. We also produce physical reports. This one people can see later. It's Waldenstrom's macroglobulinemia, which I shall talk about in a minute. But basically, you're trying to gather data over a period of time which allows you to study a specific disease or condition. So let me relate that to rare, because discussions with Tony, there's discussions about real-world evidence and real-world data and big data and all these huge, great things. The way that we look at it is about real-world activity. That's about close, about intimate support to a patient group to look at your patients and your disease and improve the quality of life and the outcomes for the patients of that group. Clearly, where there are small numbers, it can make those visible, and I shall show something on that in a minute. It can also be used where clinical trials are impractical, and I've listened with interest to Rob about the huge amounts that is spent on the trials and Novartis have kindly funded. One of the other things is informing regulatory bodies, so NICE and others, and getting drugs approved. So what can you collect in a register? Well, pretty much anything. Demographic data, and I was very interested with Jackie there saying about all this working information about working, etc. You could collect that sort of information as a potentially a sort of side lobe to the main sort of clinical thrust, if that's the way you wish to go. So a detailed history of the patient, of the disease, of coexisting comorbidities, and the cycle of treatment with follow-ups. And one of the things you can do is get patient-gathered data. We call it PROMs, it's also called PROs and various other acronyms. So what is PROMs? Well, it's the ability to send out automatic from the database, so you don't have to do anything except set it up. So either a text message or an email that can be event-driven or time-driven or ad hoc. You can send that out, and it can be as simple as here. There's just smiley faces like you'd see in Tesco's or at Border Force to say, did you have a nice day? We also have a list of 40 standard instruments, the EQ5Ds and all this kind of thing, or you can design your own questionnaire to suit your specific needs. That can be provided we can provide it up to 18 languages, so many languages from around the globe. One of the good things about it is it eliminates bias. So one thing I've come across is clinicians who say, well, Mr. Smith, how are you feeling today? On a scale of 1 to 10, is that a 4 or is that a 6? There's potential bias there. So doing the PROMs on your own means that you can have an unbiased view about how you're feeling or how you're thinking. So I'd say any questions here, but we're keeping going. So please ask me afterwards if there's any questions on that. So Waldenstrom's macroglobulinemia, and it's taken me a long time to say that. I shall abbreviate it to WM. Essentially, it's a blood cancer. It's a very simple thing. And I'm calling this our classic registry because those 200, or by about a dozen of those 200, are registries where a clinician has come to us and said, we wish to study this in this manner. So a chap called Rory Morrison, and I know there's at least one Radio 4 listener out there who I spoke to last night who might know who Rory Morrison was. He was a Radio 4 presenter. He had WM and died. He made a bequest to the treating clinicians to set up the WM registry. Currently there's about 1,600 patients on there, and within 12-18 months of getting up and running, they produced a report. They actually sat down and looked at all the data, And one of the first stunning things to come out of that was an alteration of the disease profile. So the assumption was this was a disease of elderly white males, which is completely wrong. Elderly white males had taken the trouble to diagnose and self-refer, hence that profile. The registry showed that the actual disease profile is onset typically from the 30s, mid-30s, and it's about 35 to 40% female, so significantly different. They used a lot of the PROMs to get ongoing information about the quality of life and the condition of the sufferers. And they get a 70% odd return on that, which compares very favourably to the sort of general clinical database we do, where a 40-45% return on PROMs is actually pretty good. It's gone through a couple of iterations, and we're now just going into a sort of third phase with it, third reporting phase. The second phase was supported by Janssen, which you'll see why in a second, and the next phase is being supported by a company called BEHÇET'S, both with interests. So in the initial stages, there was a whole raft of treatments, and I think the registry focused in on a couple of treatments. I took out the names of them because it was one of these alphabet soups, but basically they just tracked the patients through that. Then in 2017, Janssen had a drug approved, they supported the registry, and as you can see, they've been able to track that the patients have responded quite well in a majority of cases. They've got clinical data. And I just extracted this from the third report, which basically says they're working with commercial partners, brackets BEHÇET'S, to ensure that the decision-making process in regulatory bodies is appropriate for new therapies. In other words, helping to get their drug approved as we go forwards. In the best Monty Python tradition, and now for something completely different, Castleman disease. It's basically a lymphoproliferative disorder. They don't know if it's a cancer, if it's an autoimmune disease, or infectious disease indeed. So I remember this quite clearly because it was just before COVID struck. The leading haematologist spoke to us and said he'd like to set up a registry, but he wanted something slightly different. So the best way I can describe it is to take you through the process that we developed it. But he eventually secured some funding from a pharma company, which again had an interest in it. And this is what it looks like, or how we built it up. So the first thing is there is a presumption that your average GP or clinician in hospital will not see a case of Castleman disease. And as my partner was eventually diagnosed with lupus, I can understand that. She was being treated for preeclampsia, and we just happened to have a passing rheumatologist that said, hang on a minute, is it lupus? So to have had this kind of facility where a suspected disease could be referred on, in this case you've got, if there's not urgent, you can refer to a website. If it is more urgent, the clinician can self-register 24/7, just they need a GMC number, their name and a valid email, NHS email address. They can self-register, they set initial anonymised patient criteria on there, or case criteria, and that's then alerted to this network. And they also get a confirmation back. From that point, if it's urgent, if they're in ITU, they can get an immediate call back from one of 4 or 5 national specialists. If not, they're referred on to the National Advisory Panel, which is a regular monthly, 6-weekly get-together on a Zoom call with the local clinician, with the experts. They then further diagnose and advise, and they put that treatment back to the local clinician, so they handhold in the local centres rather than bring them into the centre. So I ran up a month ago, the guy said, I had to do this presentation, how should I sort of present it, what could I say, because no sort of observations have been reported on this yet. And his first comment was absolutely amazing, totally outstanding. They've got consistent diagnosis at a national level about Castleman's, and they're getting more and more consistent treatments. We've currently got 45 confirmed patients, and he's seeing about 5 or 6 patients a month referred to review this. And often one of those is an ITU case, which was the original premise of being able to set up very quickly. As an interesting aside, he also said that he had a confirmed Castleman patient come up to him and said, please sir, can I go on the registry? He looked it up, and that patient had actually been put on the registry when he was out cold in ITU, so he'd already been picked up. So they have these ongoing calls supporting the local clinicians. Observations. Firstly, they're thinking maybe Castleman's is not quite as rare as they thought it was. A bit rarer than they thought it was. But is that a question of people going undiagnosed or clinicians unaware? And those are things to be looked at through the registry. More specifically, the multicentric version of Castleman's is presenting more often, and that has resource implications because it's a more complex disease to treat, requires more clinician time. And the last one, AKU, alkapinuria, or black bone disease. It does what it says on the tin, turns cartilages and bones black. There's a guy called Nick Siro, who any of you who work with Beacon and things may know, because he helped to found it. They found that a chemical called nitisinone, formerly a pesticide and later turned into a drug, actually breaks a biochemical chain which causes this problem. So we worked with Nick. We met him at the Beacon workshop in November 2022, and by January 2023 we'd agreed to move forward with this. How to put this delicately? The lead clinician didn't wish to get too involved and too engaged with it. So Nick opted to have an entirely patient-led, patient journal approach. So this is my journal and my journey. Each individual patient gives a first personal view of their experience. And the aim is that they'll have a view of how the disease progresses, such that if a parent presents with an infant and said, my child's got AKU, in the future there'll be some way to sort of show and signpost to how that child's development's going to go. As I say, we developed it in about 6 months at the end of the day last year, and then it took us from Christmas last year to Easter this year to just sort out the GDPR bits and pieces and make sure that was all tickety-boo. And I apologise, this is a real eye chart, but I've just extracted that directly from the report that we provide to AKU monthly. And it says that we've now got, and this is without any prompting or promotion, we've got 66 countries who've registered people. Sorry, 26 countries and 66 people have registered. And of that, 30 have actually submitted cases, patients. And some of that is because this is a parent and a child, so that's probably why we've got 2 registrations for 1 submission. So just to conclude, what do I suggest? We suggest that makes a successful registry. Well, we think about what you'd like to find out. Think about what you'd like this report to tell you in 2 years, 3 years, 4 years, whatever. Then work back and choose the set of data fields, the information you need to gather to support what you want to learn and understand. One of the things, particularly in the classic environment with clinicians, it needs to be easy to use. If we can't get a clinician to complete this in 3 to 5 minutes, we don't get a great deal of compliance. So simplicity. Obviously, the more complete and accurate the data, the better representation and the better outputs you get. And I just put a little brackets there, a PS, GDPR. It's not difficult, it's not complicated, it just needs a methodical approach to joining the dots. And I strongly advise if you go for a registry, you start looking at the GDPR aspects when you start looking at the data aspects. So I'll just say thank you for your attention. I'm here all day if anybody wants to ask questions about specifics. I'm joining the panel, I believe, with Prof Moots this afternoon. So there we go. Thank you very much for your attention.
Thanks, Martin. Thanks, Jackie. We've got about 5 minutes spare. I know I can't hear any rumbling tummies, so if you'd like, we can just have literally about 2 or 3 minutes just to answer any questions. It's great. Some people are asking questions online. We're trying to answer them as it goes through. Just to mention, somebody mentioned the importance of being careful about coming down off steroids. So a lot of people can take steroids for like prednisolone for long periods of time, In many cases, as you don't need it, you can come off and stop the drug, but you've got to be very careful for that because your body can become accustomed to it. So most doctors would be very careful to recommend something called a short synaptin test. Because if you take steroids for a long time, your natural steroids made by your adrenal gland kind of give up. The gland shrivels up in disgust because it's getting the steroids from outside. And if you suddenly stop the steroid, you can have a nasty thing called an Addisonian crisis. That can be predicted by a short synaptin test, and if that test is fine, people can come off the steroids. If it's not normal, you might need to be on a low dose of a different steroid just to replace that naturally. So thank you for the person that mentioned that. Somebody else also mentioned about can people get second opinions if they've been to one centre of excellence? Are they able to go to another centre of excellence for another opinion? Sadly, the answer is no. When we were set up by the NHS and NHS England, they consider that each centre can provide a gold standard, and I always recommend that if somebody's not happy with something that's gone on one of the centres, you should tell them about it and take that up with them. On the other hand, if you're seen at another hospital that's not a centre of excellence, it is possible that we can give second opinions at one of the 3 centres of excellence. So that's something that we often hear about. And I always think it's best to take it up with the doctor that's particularly looking after you, because often things can be rectified that way. So we've got a couple more minutes. I think we've gone through most of the online ones. I don't know if you have any other burning questions. Don't forget it's lunch next, and don't forget we'll have a Q&A session a little bit later on. But if there's anything you're desperate to say, now's the time. Yes, lady over there. Get the microphone and then we can all hear.
I just wanted to ask what you said about steroids. Is that also steroids that you put in the eyes? Because I have had tablet steroids, but I've also had steroids for my eyes for about 4 years.
Thank you. That's a very good question. It's not the same sort of thing with the steroid with your eye. The nice thing about giving steroids to either just your mouth and a mouthwash and an ointment, or to your eyes, you're getting a big dose just to the bit that needs it. If you're taking steroid tablets, then it tends to go around the whole body and can have an effect on the adrenals. If it's just in your eyes, it's much less likely for that to miss. Other things you can have potential problems. And it's nice to know that we have Phil Murray, who is the ophthalmologist at the Birmingham Centre. He's lurking around in the background, answering some questions online. But it's not the same issue with regards to the eye, so don't worry. I think everybody's hungry. Give you another quick opportunity if you want to ask a question. And if you're thinking about, oh, it's a stupid question, there's no such thing as a stupid question. If it's something that you want to ask and you're happy to do it out loud, you can do it with a microphone. If you want to just grab one of us over a cup of tea or whatever we're having for lunch, that's another way of doing it. I'll hand over to Rachel now then. You've let us off lightly. Maybe you're saving them all up for a bit later.
Yeah, don't forget, if you're feeling a bit uncomfortable about asking a question in the room, you can always write it down and pop it in the sort of question and answer box at the back, and we'll do that during the medical panel. So we are going to break for lunch now. Just want to remind those people that are online to log back in after lunch. I hope you've got something lovely planned if you're watching from home. But for those of us in the room, we're ready to break for lunch now, which will be served, I think, at the back. Oh, over there. Be served. It's not quite arrived yet, so we might have to just network. Okay.